Yes, good.
This
okay.
is Lakshmi.
Did you all read it this weekend?
Yes.
Yeah. Okay.
Yes.
I thought it'd be useful for folks to actually see this and then to talk about it before we formulate a response, because we need to reply to as many of these we find out about in order to have input. And then also, this one in particular, the counselors are excited about, and they're saying that this is going to be recognizing counselors as billable entities, which I don't believe is the case from my reading of it. But anyway, so basically, what I thought we'd do is just go through it and then see what people's thoughts were about the aspects of it and what we would want to comment on. And then I was going to show you a copy of a comment letter that we've done in the past. Actually, it was basically Kay Jewell and myself on behalf of ACMG last summer. And then I think we'll have enough time to pull up the information about the clinical lab fee schedule meeting that's coming up this Thursday. And even if we don't have anyone present at the clinical lab fee schedule meeting, people can, log in and listen to that webinar. And we have a window of opportunity to submit written comments about the clinical lab fee schedule also. So let's get started here. Just to educate people, this is a draft local coverage determination by CGS, which is the MAC for, in this case, Kentucky. I think they're also the MAC for Ohio. And this is their proposal of a coverage decision for BRCA 1 or 2 testing. And there are different aspects to it. Some of the aspects are, what we would comment on is the procedural way they're doing this. And one of the things is at the very beginning is that they're talking about this policy only applies to BRCA testing that's undergone a technical assessment with MolDX and received a favorable outcome. And so one comment that we're going to make, and Kay and I were talking about this, is commenting on how this is a violation of the policy for making a local coverage decision, because they're essentially deferring to another MAC's decision, which they cannot do. And we want to be sure to emphasize that, because we want to always keep pushing back against Palmetto in the MolDX program as being sort of the go-to policy maker for all MACs, because it's really not good. And Sheila, I'm sure you can weigh in on that.
Correct. They are not supposed to be doing that, and what we've seen is that Palmetto does make the molecular determinations, and then others just follow it. And so whatever Palmetto does, everybody else just follows. And that's not how it's supposed to work. Each individual area is supposed to take into account what their area participants really need.
Right, so we'll be making that point. And so then the other aspects of this have to do with the policy regarding coverage and what the different criteria are. And I'm sure you've looked this over, and it's a very extensive list of criteria. There was even the fact that if you had a family history and you could not get an affected family member tested, that they would actually then test the patient with the family history, which was quite unique. Were there any indications that you folks saw there that you thought were incorrect or needed to be tweaked?
I thought they were pretty generous, actually. But like you said, with testing the unaffected people when there's no one else to test.
Mm-hmm. Okay. What about the limiting individuals of Ashkenazi Jewish descent to only the 3 founder mutations?
Actually, on that point, it actually says single site, which is only one mutation, which is the familial. I don't think they said the 3, which we should certainly consider doing all 3.
Well, look up.
No, down it does say individuals, on page 3 it does say individuals of Jewish descent. Testing in this situation is covered for the 3 founder mutations.
Right.
And not the full sequence analysis or duplication.
Right.
Oh, sorry, no, I was going on to number 4 where it says known familial mutation. Okay.
That's just the term for targeted mutation.
Sure. So is it appropriate to just limit individuals who are Ashkenazi Jewish descent to just the 3 founder mutations?
In our practice, I think that's a good start because in the past they didn't allow anybody who's unaffected to be tested at all. So it's not unreasonable.
Okay.
What it says.
Okay. Of course, the thing is, somebody may not.
Tracy.
Go ahead. I'm sorry.
I was just going to say my understanding of reading it is that it's not that they're encouraging sequential testing, it's that they will only cover that. And if
Correct.
it's negative, you're done.
That's the point I wanted to see if we wanted to discuss.
I don't read it that way. I read it that if you have no other indication, if that's your only indication. If you fall under another indication, it doesn't matter if you are or are not Ashkenazi.
That's the way I was reading it.
That makes more sense then.
I think this was taken from the NCCN guidelines.
Okay. Just wanted us to carefully consider this. Okay. And then the multi-gene panel section, what did you think of that? It's on the screen. It's page 5 on the screen.
I thought the second point might be a little ambiguous, where it says all genes in the panel are relevant to the personal and family history. That might be open to some argument, perhaps. I guess what they're getting at is we don't want you doing like an all cancer panel if they only have breast. I guess that's so. I guess that's.
Yeah, but that's becoming a little more and more difficult to determine, I think.
Yeah, it is.
Right.
Okay. But by the same token, if you recall, there was like a comment paper in New England Journal when they had the whole personalized medicine thing of this woman who's a PhD researcher who had breast cancer and she had gene testing. And one of the genes on the panel, she questioned why it was on the panel. And pretty clearly, if you looked into that, this company was including a gene that might someday be associated. They were actually doing, collecting data, on this target, which, is kind of questionable, I would think. Okay, and then
I think it's all right for right now. I mean, I don't know that you can really argue, and I think this is generous to even go to multi-gene.
I agree.
That's very forward-thinking, actually.
Right.
And the last point is actually quite well taken. The individual meets criteria for at least one other hereditary cancer syndrome for which there's testing criteria, but including but not limited to. So I think this is much more progressive than previous recommendations.
Okay, all right. And then where they start talking about counseling is in this footnote.
But that's what we want, isn't it?
Right.
Right, we want to make sure there's counseling.
Yeah.
One of the things that's gotten some people concerned is that they want the geneticist or genetic counselor to not be employed by a commercial genetic testing laboratory.
I think that's appropriate because you have a conflict of interest.
I agree. That's because Myriad had, sorry if there's anybody connected to Myriad on this call, but Myriad did have people placed in offices. supervising not genetics professionals, but other office staff that were kind of trained.
Okay, and it's not really a stark violation because genetic counselors are not physicians, but it does sort of get into that territory. Okay.
David, there's one question I had in coming back to the definition they use. For instance, at the bottom of page 2, BRCA1 and BRCA2, genetic testing for susceptibility of breast and ovarian cancers covered in adults. And then this parenthetical, I didn't know if that's a standard definition by full sequence analysis and deletion duplication analysis of common variants. Typically, they want to look and sequence the whole gene, but maybe I'm mistaken. Is it intended that common variants is standard language? I worry if you do full sequencing of the gene, that would that run afoul of this policy?
Generally, what happens in the oncology world is that the first thing they will do is request sequencing. If they don't find anything in the sequencing, then they ask for common duplication deletion variants, because that's not detected in the sequencing. So
Correct.
This is actually pretty reasonable.
Okay. Because it does say full sequence analysis, and then of course if that's negative, you wouldn't want del2 testing.
Mm-hmm.
Okay. So we would comment then about the counseling aspect, and I would check with our leadership to make sure if we say something about that we think it's appropriate to not have the lab employed counselor involved, but that might be a political decision rather than any other kind of decision.
I still worry about a conflict of interest there. I mean, I just do. Yes, they may not fall under Stark, but there is a conflict of interest. Now, maybe if we get pushback, what we can say is, they can do the counseling, but they have to inform the patient in the informed consent that they do have a conflict of interest.
Well, the alternative is that the real counseling that they could do is the post-test counseling as opposed to the pre-test counseling.
Right.
You might
Can I
get some
for
pushback.
clarification on this as well?
Mm-hmm.
So if your academic institution is offering testing, so for example, I'm at Vanderbilt, we don't offer BRCA1 and BRCA2, but they may someday, goodness knows. Does that mean that since the lab is at Vanderbilt, I cannot use a genetic counselor employed by Vanderbilt? Because this doesn't really say commercial.
No, it says here a laboratory that is part of an integrated health system.
Oh, I'm reading in a different place. I'm reading under number 5A.
Excludes. It said it excludes individuals who are part of an integrated.
On the screen right now, do you see this?
Oh, okay.
Okay, and it says excludes individuals employed by or contracted with a laboratory that's part of an integrated health system.
Okay.
You have genetic counselors connected with those laboratories in some places and genetic counselors who are not. So our genetic counselors, if we were to offer BRCA testing in the lab, the genetic counselors are actually not in part of the laboratory. They're part of the clinical genetics division. So there's really no conflict of interest there.
Right. I just wanted to make sure the wording didn't exclude it.
Right. Yeah, they've done a pretty good job there. Okay.
Can I just go back to that number 3 where there was the family history of cancer indication?
Sure. Is that on page?
That's on page 3 as well
it's
at
on
the bottom.
Now, starting here.
There. So it says, just going back to that, they are saying they will permit targeted testing for, wait, hold on. Is that the right page?
Okay, I've got it on the screen right here. Can you see it?
Yes.
Okay, so
the next page, sorry, it's on the next page, number 4, where there's known familial mutation, right there.
Right.
It says BRCA1 and 2 testing for susceptibilities covered in adults as medically necessary with single-site analysis for the known familial variant. So in general, that's fine, but where the person is Ashkenazi Jewish, should there be a comment here about doing all the 3 common founder mutations because they're common enough, it's like 2.5%, to not restrict to the, just the known familial mutation? That's something our counselors have.
So you mean you could have a woman who has a family history of a family member who had a BRCA1 gene change of some sort?
Yeah, and if she's Jewish, if she's Ashkenazi Jewish, she could well have not that mutation, but another of the 2, the other founder mutations.
But she would have gotten from the other side of the family or something.
Right, or whatever, just out of population frequency being 2.5%.
Well, if we can find references to back that up as a recommendation, we could certainly add that.
So where there's a known familial mutation in an Ashkenazi Jewish individual, and it's a founder mutation, that individual should be tested for all 3 and not just that one.
But I mean, we'd have to be able to refer to literature rather than just making a comment.
So what would you like? The population frequency and other
show
recommendations?
Population frequency would do it, because for this case scenario, you would have to have a study that proves that indeed we tested for a targeted mutation, but in the Ashkenazic Jewish population, we found...
I think we could find that, actually.
Right. That's what we would have to do, because we can't just have opinion with criteria. But that's...
So that's my homework. I will try to find something.
Certainly, could be a valid concern, yeah.
Okay.
Okay. And then, of course, the real issue we have here is that, this is Medicare coverage, but Medicare coverage decisions, flow through the entire health system. So we want to be very careful about that. Okay?
Right, because private insurance looks at these policies as well.
Right.
Okay, so I'll try to find something.
Okay, good. Okay, and then there was this stuff here about the test is once in a lifetime. If you've been previously tested, repeat testing prior to Lynparza therapy is not reasonable. And I just don't know enough about Lynparza to know if there's something that is more modern technology would be necessary if someone had BRCA testing done 2 years ago or 3 years ago. Do you know anything about that? Is there a specific mutation that Lynparza is related to?
I believe there is something. I can pull it up.
Yeah, because I sort of saw that and went, I'm not sure I understand this. And if it's like something that might not have been detected, on 2 years ago's testing, maybe there should be an exception.
What about a patient who may have had sequencing but not del-dup or not the latest rearrangement testing?
That was my big question.
Okay.
That's the drug for ovarian cancer, for advanced ovarian cancer.
Mm-hmm.
If they have a specific or specific mutations, they can get this drug, but I don't know why you wouldn't have picked that up on the original sequencing.
I don't know. That's why I was asking. I'm not a molecular person.
So David, the answer to your first question is the bottom of page 7, the top of page 8. They sort of reference that any germline BRCA1 or 2 mutation as salvage therapy will qualify you for Lynparza. I think the bigger question to echo is, what about reinterpretation? Because I think there's 1, do you want to resequence? And 2, do you then just want to reinterpret? And I guess 3, if the original sequencing was incomplete, i.e., if that is to say they didn't do also deletion duplication testing, I think it's worth, I don't know that it'll make it into policy, but sort of discussing this idea of things will be sequenced, but there's the second idea of reinterpretation of the sequence data with additional clinical information years later.
Right. So what would be a reasonable time frame to bring up the concern about reinterpretation?
I think it's more if someone had just a, as you said, either just the 3 common mutations or a more restricted panel earlier, a restricted test earlier, and then have ovarian cancer and fail their chemo cycles, and now potentially could be a candidate, but they would need retesting with del-dupe or something else to actually rule out a BRCA mutation more conclusively.
Okay. So under the limitations here, we want to
get it.
Say define previously tested.
Right.
It's the way that says put parenthetically sequence analysis and del-dupe testing.
Or I would also throw in the 3 mutation panel. So if an Ashkenazi Jewish person had the 3 mutation panel, can they now go back and get full sequencing?
Correct.
Right. Okay. 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 All right.
Well, the once-in-a-lifetime sequencing should include the most complete testing available.
Right.
So how would you phrase that? Because
if the testing that was previously done does not include
the
complete sequence, and they'll do, I guess, because that's
you want to have the language in here so that the ordering physician could make the argument for medical necessity by citing that.
Right.
Okay.
Right.
And I think we do have to put in, make a comment about definitions, resequencing versus reinterpretation of data.
Okay. And I think, yeah, go ahead.
I think we should find a reference regarding somehow the reinterpretation as being necessary.
Okay.
Do you guys know of any labs that are charging for reinterpretation at this point?
Not really. I don't think they charge. I think.
Well, that's the thing, is that either I can't get a lab to reinterpret because they can't bill for it, or they reinterpret and there's no fee, so therefore it wouldn't matter.
Right. Like,
but
it does update.
Other, because they can't get, they can't bill for it, then it becomes important.
Say that again.
If they're not billing for it, then that is their issue. But if it is an issue of they won't do it because they can't get paid for it, that is an issue.
That's been my experience. That's what I'm saying, is that I don't think there's any labs out there right now that are billing for reinterpretation.
I agree.
Yeah, we recently looked into this, so I can tell you. So Ambry said this was in reference to exome reinterpretation, but I think it's a good guide. So Ambry said they'll reanalyze data at no charge within 2 years of issuing their report. You just have to order it. ARUP said that there would be they would be able to reanalyze it. There would be a cost. They didn't know what that cost would be yet. Same for Emory. They said they were trying to create that service. Baylor sort of again was didn't commit. They said if there are new gene disease associated. Okay, there you go. Same with Cincinnati Children's. They started saying we're just figuring this out. So there are a couple labs out there in the works. I think Ambry was the only one that had, or the one with the most formal policy. But
historically for BRCA, I don't think there's been charges for reinterpretation.
But what I'm saying is, though, when it comes to this document, if a person had a mutation analysis some number of years ago and it was negative, and now they would qualify for Lynparza if they can find a mutation, you're basically, if the lab that did their study won't reinterpret, they're hosed because they can't get a new order.
But you're not, if they have the complete sequencing and I think it's more of a kind of increasing the level of testing rather than the reinterpretation. If they were negative and they had all those three things, you're not going to ask for reinterpretation.
Well, but they may have had a VUS that is now
but then they would have,
Who do you get
reported it
next?
as VUS then. It wouldn't be a normal result.
Okay.
I mean, if they had a normal result, you wouldn't. And I believe that most of the time they have not billed for reinterpretation of VUSs.
Yes, but now we're hearing that that there are people looking into billing, so we have to be very careful because you don't want the LCD, because I don't know how often these LCDs are actually re-looked at, whether it's every year or every 5 or 10 years. Cheryl, do you know how often they're looked at?
I do not, but I would think that for a genetic test, it probably is not that often.
You know, we can ask Kay Jewell about that because she was the medical director for a MAC.
They haven't even mentioned reinterpretation anywhere, so should we not just say? Should we just not say anything?
No, then it won't be covered.
Unless
if
it's
not
a
mentioned,
separate.
it's covered.
So there's no discussion at all of reinterpretation anywhere in the document, right? Or review of data.
So I think that needs to be a comment that we think that we need to add reinterpretation or a review of data.
Mm-hmm.
And we don't know what there wouldn't be a code. Is there a billing code or a charge that is assigned to this?
I think the way competition is for those labs out there, you should be able to find somebody to do it for nothing.
Right.
Right now, that's true. But
and with all the public databases,
as reimbursement gets tighter and tighter, you are going to find that you cannot get that done. So we can't go on what's right now. We have to try and look beyond the scope of what's happening right now and kind of look into your crystal ball.
Let me ask a question here, though. Does every laboratory have to have a medical director?
I don't think so. Wait.
No.
I think they do, don't they?
Yeah.
As a medical director who got laid off from Signature, I can tell you that it's not required.
Okay. So that was my question. Because if the laboratory had a medical director, they could charge for a reinterpretation as a consultation by the medical director.
That would be good.
Right.
Well, then we need to comment that should be covered.
But you see, it's a physician service, so it wouldn't even be mentioned.
Well,
okay.
Because it's all outside this policy, which is exclusively about testing and not about interpretation.
But you do want to put in some comment about if the test was done a certain amount of time before that it should be re-looked at. Is that correct?
Or as necessary, according to the state of the art.
Okay.
I think that's going to be too broad, and they're not going to like that. I think we do have to put some kind of time limit, like if it's been done within the last 2 years or 5 years. And I know this area is moving fast. The reinterpretation can be done quicker, but the actual repeat of a laboratory test, I think we have to be careful.
Yeah.
I think with these two, I think this is different though from like whole exome and sequencing and the multi-gene panels. I think that it is much more appropriate to have review of data for multi-gene panel sequence variants than for the BRCA. So at least in the multi-gene panel area, this could be much more important. I think with BRCA, there's just so much experience now, and as long as that's in the public database, I think you would get a reinterpretation of BRCA. But it's where the multi-gene panels come in that we're going to have the issues.
I agree.
I think one of the other things that will play into this over time, especially over the next 10 to 15 years, is that if somebody did have whole exome for another indication, are they then going to say, no, technically you've already had sequencing of BRCA1 and BRCA2, even though the coverage may not have been appropriate for that indication?
This policy doesn't sound like they think that sophisticatedly. I think, and especially if you define and say BRCA testing, and say, i.e. full sequence analysis and they'll do testing, close parenthesis.
Okay.
That sort of takes care of that.
And then the only other comment I had, or that I've thought of, is so I am not a cancer geneticist. I'm a pediatric geneticist, and I order BRCA1, BRCA2 when I have a phenotype of Fanconi anemia.
Mm-hmm.
And this doesn't address that at all. And so I'm not so worried about it in the Medicare population, but I have come up against difficulty getting it in my pediatric population because it doesn't fit these guidelines.
So what we've done in our pediatric patients is we've done the breakage testing, so we avoid the mutations as far as possible.
Right, but then I seek mutations as well.
But then it would fall under the multi-gene panels. But another thing is Medicaid might not follow this policy at all. Is that correct, Cheryl?
Medicaid would not follow this policy at all.
Okay.
But private insurances tend to adopt these.
Actually, I don't think that the private insurers, and I can only talk about the Blues and Aetna where I work, but they have their own policies. They do not take Medicare policies. They may use them as a starting point, but they do their own evidence background and they draw their own conclusions. And I know that the one that the Blues uses came directly from the NCCN because the year that the NCCN changed their guidelines to make them more liberal, the Blue Cross people did also.
And I know I just dealt with our health plan and this coverage, and they also went with NCCN guidelines, basically.
Mm-hmm.
So this is slightly different than even what they put in. So, and they relook at those policies every single year.
Right.
Okay.
A health plan is required.
Big concern.
What?
So then covering Fanconi patients should not be a big concern for this policy then?
It would be hard to get it into this policy for Medicare.
Yeah, I think it's a kind of a different
separate
situation.
Yeah.
That's fine then.
And I think on a case-to-case basis,
I would say, though, if you made a request for it, you would have to explain why you wanted it. It would have to be approved by a medical director. You could probably not get it through without that in most health plans that have authorizations.
Yeah.
Okay. Good. So
thank you.
Let's go now to another section here which deals with genetic counseling. It is the part that has the counseling community thinking that this is going to say that Medicare is going to pay for genetic counselor providing counseling. It's this paragraph here. And I think in particular it's because the U.S. PTF has published recommendations and that the Affordable Care Act requires that private group and individual health plans provide coverage for this. And they're interpreting this as saying that so it should apply to Medicare too, and I don't read that here.
we do get coverage for patients for genetic counseling at our center.
Medicare pays
is there a problem?
Counseling?
I mean, there's two ways that we're doing it. One is that we're using the 96040 code with a physician on site, but not necessarily face-to-face. And that's the genetic counseling code.
Yeah, but whose name is that?
It's on the physician, in the physician's name.
Right, so that's...
But I believe that in areas, in New York, we don't have licensure, so I don't know if anyone else has experience where
we do the same as New York, and we don't have licensure.
And we do get coverage either as a consult code, with the face-to-face time, or with the genetic counseling code with the
But see,
physician on site.
happening is Medicare is paying the physician, not the counselor.
Correct. But
Correct.
the physician is the oversight of the, is the umbrella under which the counseling is being built. So technically they are providing coverage for counseling.
Okay. I just wanted to call that to your attention because I don't read this.
In Medicaid, most Medicaid plans, if they're following what the feds want, will cover genetic counseling.
Correct.
But they cover it at such a low fee that they might
yes.
as well not.
Exactly.
But the point I wanted to point out here is that the counselors are feeling that this means that Medicare is going to pay genetic counselors for doing genetic counseling in this setting, and I don't see that.
I don't see that.
I don't either.
Right. Okay. But if we make any comment about that, the political ramifications are such that I don't think we'll make a comment.
No, especially since we're not reading anything into it.
Right. Okay.
There's nothing there that says they will pay genetic counselors directly or what codes to use.
No, it just says counseling needs to happen and it needs to be paid for. It doesn't say who's doing the counseling. And it doesn't say Medicare is going to pay. It says that private group and individual health plans do. Okay. So let me send you a copy, or let me see if I can pull up for you a copy of the previous comment letter that I've sent out to the same MAC, just a good measure. Can you see it on the screen?
Mm-hmm.
Yes.
Yep.
And so it's the same Dr. Earl Berman, because this time I think it's in Ohio, they're doing a coverage determination, and we usually have a preamble. It'd be nice for them and talk about ACMG and what we do and why we care and why we have an opinion. And then we go into giving them, comments about specific parts of the proposed LCD. And then as you see here, the same kind of comment here about Palmetto MolDX, being, used for them for their decision making. And this, I'll send you a copy. Did Natasha send you a copy of this?
I don't believe we got a copy of that.
Okay. Well, I can send everybody a copy of this just so you sort of have something. And then we have until August 3rd to submit. And so, I figured that's a fair amount of time. I just wanted to do this by a webinar today so you could actually see it, and we could actually talk interactively looking at the document. But I think follow-up could be done by email or just by a conference call, unless you think a webinar would be valuable, and we could try to get that set up again.
Just a question, was there any response regarding your comment about the MolDX?
No, but he did contact me because I said we could provide more detailed comments, and I provided him some more detailed comments, which are here. So I followed up. That was in July, and I followed up in August with additional detailed comments because he responded to that. But in terms of them actually saying that they responded to it and say, gee, you're right, you caught us, nah.
I think it would be very difficult for every state to come up with a committee that would be capable of reviewing these things. So they go to one, Palmetto, the people who...
Right, we understand, but we would prefer if you keep pushing back against Palmetto, that maybe we can find somebody else they can go to. Or they should have a genetic advisory committee, potentially, But we can dream. And then the other thing I wanted to share, because Sheila asked me about this, is that this Thursday is the clinical lab fee schedule meeting. And Mike Watson and I are both going to be in Asheville at the CERC meeting giving talks on Thursday. And so we're not going to be able to attend. It appears there's more going to happen than just people commenting about the codes that were on the list. but we don't have any evidence of what it is. And so it would be useful for us to, at least have people listen in. I also I sent that email last week. About a month ago, I registered 2 slots for ACMG to be in person at that meeting. And if there's somebody on the economics committee who lives near Baltimore, for whom it's like something they could do, they could attend this meeting in person, which is always a very educational experience. To see and meet the other organizations' representatives is always highly useful networking opportunity. And as I indicated, if say someone, was close enough that they could drive, we could, I'm sure I could get Mike to reimburse the mileage expense and lunch expense for the person who did that. But I don't know if anybody here is within easy driving distance of Baltimore. Are any of you?
I'm not.
Not me.
New York
I am, but I don't think I could do it.
Yeah, I can't either.
It is pretty short.
And I feel like I don't have the experience to do this.
So what I am planning to do is try to either WebEx in or do the live stream. The trouble with the live stream, at least at my institution, is that you will lose it so often and it can't keep up.
Right.
And so therefore it becomes just an annoyance. But if the WebEx meeting number works, then that might be the best route. So I'll try and listen in while I'm doing other things.
Right. Okay. The key thing is that this agenda doesn't show what else they're going to talk about, and we expect they're going to talk about PAMA, because they talked about PAMA last year. And last year they talked about forming an advisory group, and we said they needed to have somebody from ACMG on that advisory group, and we've heard no follow-up about them creating an advisory group regarding molecular stuff for the whole PAMA process. So those are things we want to listen out for in particular.
Okay.
Sheila had sent around Aaron Bossler's presentation regarding how they think they should price some of these codes. It's similar to what AMP presented last year, although this year they've informed it more with this micro cost analysis project that they did. But, it seems to be a hard sell to convince CMS to have a crosswalk kind of process with this pricing model. They're happier putting the burden on everybody else to do the gap fill process, which is like ridiculous. So anyway, but it'll be a learning experience. And just to let you all know, this sort of is the beginning, I think, of the process of becoming, you guys becoming more educated about this whole arena, because that's truly the way that ACMG, is going to have input into these things, because everybody talks about AMP and what a great job they do, and the thing is, most of AMP's activities in these areas are done by volunteer members. Like that white paper they put out 6 months ago about the perfect storm, if you all saw that. That was all done by, the Labor Economics Committee, like people who are volunteers. And, they didn't become experts on the arcane parts of all these policies and stuff overnight. It's a long learning process. And so I'm hoping to try to facilitate that learning process for the committee. And so I hope this was useful doing this webinar today.
Yes, it was. Thank
Good.
you.
And this is being recorded, so I'll have Natasha figure out how it can be shared with people who are not on the call. And so then, Sheila, did you want to just follow up with me about how we plan about getting people to provide input into doing a comment letter?
I think what we should do is if you draft the letter up, we'll send it out for comment. And we'll post the webinar. If we can either send the recording, if there's a way of posting that recording on the economics listserv and people can actually see it, that would be one way. I don't know if we can send a recording link possibly and just post it on the web under the Economics Committee.
I'll have Natasha look into that.
Because I think probably the best place would be under the Economics Committee site and post the web there and say, here's the link to it, and here's the comment letter, and this is how long you've got to comment. What does everybody else think that's on the call?
Mm-hmm. That's fine.
Sounds good.
Okay.
Okay.
I'll have Natasha figure out what we can do with this recording.
All right, that sounds great. And I did take notes on the comments, so I'll be able to make sure everything's in the letter. Or do you want me to send you back that presentation with my comments on it?
Which presentation?
I mean the PDF. So the original LCD that you sent out, I put comments on as people were talking.
Oh, good. You did that. Okay, excellent.
You?
Yeah, that'd be great. Send it to all of us. That'd be cool. Yeah.
All right, great. I'll do that.
Excellent. Okay. Well, thank you all.
Just don't pay any attention to misspellings because I'm typing.
All right. Well, thank
Thank
you all.
Thank you.
Thank you.
Bye-bye.
Bye-bye.
Bye-bye.